Welcome to the ONC HTI-1 Final Rule Decision Support Interventions Information session. My name is Tom Deneen with Kaufman & Associates and will be assisting with the logistical support for this Zoom session. To ask questions, click the Q&A button at the bottom of your screen. However, please note that there are restrictions to what can be answered due to the Administrative Procedure Act. If you have general comments, please click the chat button, also at the bottom of your screen. This will pull up the chat box, which will open to the right side of your Zoom interface. Please use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the Q&A portion of the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Jeff Smith.
All right, well, thank you. And welcome, everyone. This is the first of what will be a series of deep dives on the HTI-1 final rule. And so we're delighted to have you here this afternoon. If you can go to the next slide, please. Okay, so now we've got an obligatory disclaimer here for you. The materials contained in this presentation are based on provisions contained in 45 CFR Parts 170. While every effort has been made to ensure the accuracy of these restatements of these provisions, this presentation is not a legal document. So for the official program requirements, please look to the Code of Federal Register, and please note that other federal, state, and local laws may apply. As well, please note that this communication is produced and disseminated at U.S. taxpayer expense. Next slide, please. Okay, so this is the agenda for today's presentation. We are going to provide a little bit of background and talk about some of the policy objectives related to the certification criterion known as the Decision Support Intervention Certification Criterion. We will talk a little bit about our final definition for predictive DSIs, talk about how this definition is getting applied to then create a configuration nexus for requirements in the program, as well as talk about some of the other capabilities beyond just source attributes and risk management. Then my colleague, Jordan Everson, is going to go a little bit deeper on the source attributes and finish things up. Next slide, please. All right. So let's talk a little bit about the background, kind of how we got to where we were with the proposed rule and then finally the final rule. So next slide, please. So first, I think back in 2020, the Government Accountability Office published a technology assessment on AI and health, and they focused on a pretty broad spectrum of technologies covering clinical and administrative use cases. And really, kind of as we look behind us over the last several years, as we look back to 2020, I think we should rightly consider that across these categories, there have been numerous deployments and use cases that have genuinely contributed positively to patient care. So back in early 2022, we began an exploration into the world of predictive models in healthcare. We spoke with experts, reviewed scholarly and academic literature, and conferred with numerous colleagues across HHS and the federal government. A principal aim of this work was to really identify barriers to the optimization of predictive models in healthcare. And during a 2022 hearing of our advisory committee, we heard from clinicians that they have unmet needs for information and transparency. And they have deep concerns regarding the capacity of AI to create or recreate systemic inequalities. And really, at the time, based on a string of peer-reviewed research, it's not really that hard to understand why they were hesitant. Next slide. So for example, several high-profile papers and journal articles were written that spoke to some of the widespread harms that have been documented through the literature. For example, Obermeyer et al. Looked at one high-risk care management class of tool that was used on roughly 200 million patients in a 2019 study, finding that at a given risk score, Black patients were considerably sicker than white patients. And this is because the algorithm predicted healthcare costs rather than illness, and cost was used as a proxy for illness and was used to determine which patients ought to receive higher follow-on care and higher care coordination. And because that Black patients often receive less care and spend less care on care, this predictive algorithm was clearly biased against Black patients. Vyas et al. In 2020 did a pretty excellent cross-section. They had a study known as Hidden in Plain Sight. They looked at dozens of clinical algorithms across a handful of specialties and really found that having race as an element in the predictive model ended up disadvantaging minorities and Black patients. But it's not just race and racial discrimination that are problems. We also know that Adam Wong et al. Examined inaccuracies in the prediction of a widely used sepsis model in 2021 and found that it didn't do well when compared to contemporary clinical practice and alert fatigue. And then finally, Michelle Samarani looked at seemingly innocuous use cases that still presented challenges. Michelle looked at a no-show risk predictive model that would try to determine which patients would show up to their appointments and which ones might not. And this study demonstrated that the use of this algorithm caused Black patients to wait 30% longer than non-Black patients. Next slide. So it was through this prism of trying to understand how to optimize the use of algorithms, looking at both kind of the good and kind of the bad as we understood it, that we engaged in a series of blogs. And so over the course of about 6 months, we looked at and reflected on the emergence of AI and ML in healthcare, and especially those applications that were designed to help predict and help improve decision-making. So we spoke with experts, we reviewed scholarly and academic literature, and we conferred with numerous colleagues from across HHS and the wider federal government. And this is really what resulted in our proposals in HTI-1. And what we noticed was that information on the quality of deployed predictive models was lacking, and this information asymmetry was contributing to challenges identified in the previous slide. The next slide, please. So this is really kind of the logic model for what we proposed in HTI-1 for decision support, as well as specifically for predictive decision support interventions. We proposed an emphasis on transparency for data, performance, as well as organizational competencies. And that's really the logic that we tried to use. We thought if we could improve data on, or improve transparency on which data were incorporated and used as part of a DSi, as well as had transparency on the performance and quality of algorithms and transparency on the competencies of organizations that deployed algorithms and developed algorithms, we could develop more trustworthy, more fair, appropriate, valid, effective, and safe algorithms. Next slide, please. Okay, so now I'm going to go into some of the finer grained details of our final rule and speak to some of the important aspects of our rule that then lead into the requirements for health IT modules that are certified to the DSi criteria. So if you can go to the next slide, please. Okay, so we finalized a definition for predictive decision support interventions, or predictive DSIs, to mean technology that supports decision-making based on algorithms or models that derive relationships from training data and then produce an output that results in prediction, classification, recommendation, evaluation, or analysis. And this three-part definition is really important to kind of keep in mind as a whole. We had a lot of really good input on the definition from several organizations and individuals, and we maintained a broad scope definition. So just to kind of reiterate, the scope of the definition is broad, it's use case inclusive, it's risk independent, and it's developer agnostic. And I think it's really important to understand the reasons behind that. And that's because we wanted to cast a wide net. We think that there are many technologies out there that ought to be considered a predictive decision support intervention. But that doesn't mean that all predictive decision support intervention technologies are going to be subject to our requirements. So we went with a broad definition and then a more narrow construction in terms of which among those PDSIs or predictive DSIs will be subject to the requirements that we set forth in the rule. So I think it's kind of important to note that we did include fairly simple, straightforward risk calculators, as well as the more complex large language models and other generative AI. There are no use cases associated with the definition, so the definition applies equally regarding or despite the use case, as well as applies despite a level of risk. And I think I'll highlight that we have some technologies that are clearly high risk, others that are seemingly low risk, but I would say the vast majority of technologies in this space are somewhere in between and likely of unknown risk. But we did not operationalize and we did not define predictive DSIs based on level of risk. All right, so now that we've got an understanding of the definition, let's talk a little bit how we finalized and how we are going to apply this definition to the program. So next slide. So those of you who took careful note to go through all of our proposals at a line-by-line level, and thank you for that, will note that we did propose a configuration nexus that was focused on this notion of enabling or interfacing with a certified health IT module. And really, we proposed a combination of three questions that would then indicate whether or not the technology and the developer would be subject to our requirements. We proposed that the questions that were, does the technology meet the definition? Does the health IT module enable or interface with? And then does the predictive DSi use US CDI data elements? And if the answers to all three of those, according to what we proposed, was yes, then you'd be subject to our requirements. And we, took some time to try and explain what enables and interfaces with meant. And we clearly heard from folks that there was some confusion over that, and that this configuration nexus was rather broad. So next slide, please. So also, again, why the configuration nexus matters. This is the way that we propose to operationalize the predictive DSi definition. And as I mentioned, if you said yes to those three questions, then you're going to be subject to the requirements. We'd also proposed an attestation statement. And this would create the conditions where if you said yes to those things, you had to go through the follow-on requirements. And if you attested no, you didn't. And I would say that one of the things that we included as part of this proposal was this notion of other parties. And I think that was also, it caused additional levels and layers of complexity. And we certainly heard that. And so if you could go to click through one more there. Thank you very much. So just a reminder, other parties was a rather broad and inclusive concept that we proposed. And this would have included any other party that really wasn't a certified health IT developer, but also developed a technology that met the definition of a predictive DSi. So all in all, what we proposed was a rather expansive set of policies and a rather expansive configuration nexus that would have applied a broad policy to a pretty broad sweep of different technologies. If you could go to the next slide. We got tons of feedback and a lot of it was really very helpful. And if you could go to the next slide. you can see that where we ended up was a final configuration nexus that was more squarely focused on the technology that a certified health IT developer supplies as part of their product. And I would say that this includes predictive DSIs that a certified health IT developer authors, develops, or supplies as part of its health IT module. And I think it's important to note that this framing does keep the core of what we were proposing in terms of the requirements and in terms of the technologies and the parties that we were looking to have subject to our requirements. This does include predictive DSIs that are authored by developers of certified health IT, as well as those that are authored or developed by other parties, if those predictive DSIs are kind of sold or marketed or otherwise explicitly included as part of the health IT module. We go on to talk about in the preamble that supplied by means that certified health IT developers have taken on stewardship and accountability for that predictive DSI for the purposes of the health IT module, and that they have knowledge of its use is known by the certified health IT developer. So in instances where a health system develops a predictive DSI and uses a certified health IT module to deploy that predictive DSI, really, unless the certified health IT developer can say that they supply it, then that technology would not be subject to our requirements. Next slide, please. Okay, so here's some examples of supplied by configurations. These are all taken from the preamble, so I won't belabor it too much, but I think again the idea here is that the developer of certified health IT is knowledgeable and in some ways promoting or just supplying the predictive DSI as part of its health IT module. I'll note here that supplied by likely does not include apps that are available through a certified health IT developer's app store. And then, from a conformance perspective, supplied by the health IT developer as part of its health IT module means that developers of certified health IT are not accountable for populating source attributes for or applying IRM practices to the predictive DSI in instances where their customers choose to deploy a self-developed predictive DSI or an other party developed predictive DSI within the certified health IT module. This is true even if the customer leverages data from the certified health IT developer's health IT module, and even if the output from another party's predictive DSI is delivered to or through a health IT module. So we took steps between the proposed and the final to try and narrow the configurations for which a certified health IT developer would have to have complete and up-to-date source attributes. Next slide, please. Okay, so as I mentioned, the implications are that we've reduced the overall scope of technologies that are subject to our requirements for the DSI criterion, but we've also maintained the intent of the attestation statement. So we've finalized a construction that ensures health IT modules can certify to the DSI criterion without requiring them to author, revise, or otherwise supply a predictive DSI. Instead of attesting yes, a developer must enable access to complete and up-to-date source attribute information and apply specific risk management practices for each predictive DSI it supplies as part of its health IT module. If it doesn't supply a predictive DSI, then they don't have to enable access to complete and up-to-date source attribute information or apply specific IRM risk management practices to a predictive DSI that doesn't exist. Instead of attesting no, a health IT developer that does not supply any predictive DSI will not need to provide access to this information, as I mentioned. So we note that if after certification, initial certification to B11, a developer begins to supply a predictive DSI as part of its health IT module, it would then need to comply with all the applicable requirements in B11. Next slide, please. And that is really bootstrapped on the idea of this assurances maintenance of certification requirement. So we did finalize a DSi criterion specific version of a general certification program expectation as a new maintenance of certification requirement. And this really builds on 3 specific existing assurance conditions of certain certification requirements. It establishes ongoing obligations for developers of certified health IT that supply predictive DSIs as part of their health IT module. And these requirements are that developers who supply predictive DSIs as part of their module enable user access to updated descriptions of source attribute information. They review and update as necessary risk management practices that must be applied for each predictive DSI. And they ensure that ongoing public accessibility of updated summary information for updated risk management information is submitted to their ONCACB. I would also note that the same is true for a developer, and this assurances goes both ways. If a developer certifies to B11, and let's say for the sake of argument, they've got 2 or 3 predictive DSIs that they're supplying, and then at a later time, they no longer supply those predictive DSIs as part of their module, this assurances and maintenance of certification requirement enables them to not have to do the aforementioned requirements. So this is meant to try and keep pace with developments that may happen in the market once a developer has been certified to B11. All right, next slide. Okay, so hopefully that was helpful context. We'll go into some of the other required capabilities in B11 next. So if we can go to the next slide. There's rather a lot of text on this slide. We'll try and break this down over the course of the next few slides. I will just kind of highlight here that we did finalize a host of additional requirements for health IT modules to enable users to provide electronic feedback for evidence-based DSIs and export that feedback. We require that health IT modules enable users to select both evidence-based and predictive DSIs if they wish, as well as enable users to access complete and up-to-date source attribute information for evidence-based and predictive DSIs. And then finally, we finalized that health IT modules must enable users to record, change, and access source attribute information for evidence-based and predictive DSIs. I did mention there are, and we'll go into some detail on the risk management requirements. And I did just cover the assurances and maintenance of certification requirements to kind of review and update DSIs related information on an ongoing basis. Next slide, please. Okay, so on DSI selection, we finalized that all health IT modules certified to the DSI criterion must enable a limited set of identified users to select electronic decision support interventions that are evidence-based as well as predictive DSIs. And this is really very consistent with the paradigm that we have today in the program. Modules certified to A9 have to enable users to select evidence-based DSIs based on a set of data. And this, again, does not require that the developer author or develop those evidence-based DSIs. And we're carrying forward this same paradigm for predictive DSIs. This really does ensure that users of health IT modules certified to the DSI criterion can select either evidence-based or predictive DSIs. And it helps ensure that we don't create disparities in the market for developers who, under the proposal, might have supported predictive DSIs and those who didn't. Under this finalized requirement, we'll create parity in the market, parity across modules, so that users have better control over which decision support interventions they'd like to use. Next slide, please. So on the feedback loops requirement, we did get a lot of really good feedback on this, and we ended up finalizing, I think, a clearer construction, one where feedback loops and the ability for users to provide electronic feedback is specific to evidence-based DSIs. and that this feedback information needs to be exportable so it can be used for quality improvement or research purposes. We did finalize that a limited set of identified users should have this ability to export. And we did finalize that a minimum in terms of what information needs to be available through this export. Minimally, the information needs to include the intervention, the action taken, user feedback, and the use date and location at a minimum. Next slide, please. Okay, again, we got a lot of good feedback on the scope of what should be considered evidence-based for the purposes of the program when it comes to DSIs. We heard that many commenters were concerned that our scope of evidence-based was too broad and that associated requirements for source attributes and feedback loops were really fairly unworkable given this broad scope. So for the purposes of B11 in the final rule, we finalized that evidence DSIs are limited to only those DSIs that are actively presented to users in clinical workflows to enhance, inform, or influence decision-making related to the care a patient receives. So I know it's a rather large kind of context, but I do think, and we think generally that this is going to help constrain the number of evidence-based DSIs that are going to be subject to our requirements and hopefully help developers understand for which DSIs they need to have corresponding capabilities. So this does have implications for DSIs that health IT modules must enable selection of, as well as enable users to access source attributes for, as well as support feedback loop functionality for. So again, that is DSIs that are actively presented to users in clinical workflows to enhance, inform, and influence decision-making related to the care a patient receives. All right, I think at this point, next slide. All right, I think at this point, I'm going to hand it over to my colleague, Jordan, who's going to go a few layers down on the source attributes requirements. So take it away, Jordan.
Thanks so much, Jeff. As you said, I'm going to walk through the source attributes and then intervention risk management requirements in B11, which in many ways form kind of the two planks of the transparency related requirements in this criterion. Next slide, please. So quickly a review of what we proposed in the proposed rule, which was that all health IT modules support source attributes for evidence-based and linked referential DSIs, and then developers would attest to providing predictive DSIs that is enable or interface with predictive DSIs. And then if they did so, would enable review of source attributes for predictive DSIs. In this framework, we really combined the ability to support categories of information, that is kind of displaying fields of information, and the requirement to enable review of content related to those fields. And as you'll see in the final rule, we've split those requirements. We also propose that health IT modules enable the ability to author and revise source attributes and information, really with the idea of providing flexibility to users to customize information related to these interventions to fit their specific circumstances, and have retained this objective in the final rule. Next slide. So as I said, we finalized separate requirements for modules to support source attributes categories on the one hand and content on the other. So there's a set of uniform requirements for all modules certified to B11 to support fields, categories or fields for evidence-based and predictive DSIs to enable users to record, change, and access source attributes for evidence-based DSIs and predictive DSIs. And then in recognition of kind of the changing state of the predictive modeling landscape, we also have the requirement to enable users to record, change, and access source attributes that we have not specified. So kind of to customize what is displayed for those predictive interventions. And then we have a conditional requirement for health IT modules to enable access to complete and up-to-date plain language descriptions for evidence-based DSIs and predictive DSIs supplied by the health IT developer. So here really focus only on those interventions that the developer supplies as part of its health IT module. This approach of splitting the requirements to display fields and to modify things ensures that users have uniform capabilities, and supports users who want to identify source attributes for predictive DSIs that they self-develop or predictive DSIs they acquire and implement into their EHR from other parties. It also maintains the intent of attestation, where we're making the requirement to actually provide information on this on these interventions conditional on whether or not they are supplied in the health IT module, that configuration nexus that Jeff described. Next slide. So what are these source attributes? For evidence-based decision support interventions, we have retained essentially the source attributes as proposed. That is, we have 4 source attributes that are consistent with what's currently in A9 for bibliographic citation, the developer, the funding source, and the release and revision dates if applicable. And then as proposed, we've added source attributes related to the use of specific data for evidence-based decision support. And that is use of race, ethnicity, language, sexual orientation, gender identity, sex, and age, use of social determinants of health data, and use of health status assessment data. And the intention here is that users will know when this information is being used in their evidence-based decision support and can determine whether or not it's appropriate to include in those tools. Next slide. For predictive decision support interventions, we've finalized 9 categories of source attributes. And this is, I'll say, more specific and more numerous source attributes than we proposed, where we had proposed 4 categories and 14 specific source attributes. Looking across these 9 categories, the first 3 are really about what the intervention does, how it should be used, and how it should not be used. The next 3 are about how it was developed, including the input features, processes used to ensure fairness, and external validation of the model, if any. And then the last 3 are really about how it performed. So those quantitative measures, how it's being measured and maintained as it's deployed and in local settings, and how it's being updated and fixed based on its local use. Next slide. So within these 9 categories of source attributes, we've specified 31 specific types of information that I've listed here. I realize this is small and a lot to read, and I won't go through each in detail today, but I'll highlight under number 2, the purpose of the intervention, which is emanating from the proposed rule. We've included 4 specific source attributes: intended use of the intervention, intended patient population, intended user, intended decision-making role. And each of these were items that we described in the proposed rule as things that should be included in reporting these source attributes. And we've now moved them from the preamble of the proposed rule to the regulatory text of the final rule. And have aimed here really to be more specific and in some ways more narrow in the types of information that are required to be reported. Next slide. So as I said, the expanded source attributes clarify numerous shoulds that were described in the proposed rule preamble. And this is really in response to public comment that some of the source attributes as proposed were broad, or that commenters were uncertain what information was really being asked for. And so here we've tried to be somewhat more specific and explicit, and ultimately limited in the type of information that must be made available. A good example of this change is that we proposed input features, including descriptions of training and test data, which is relatively broad, and have then finalized use of variables in paragraph B11 for A5 to 13 as input features in the predictive DSi. And those variables are the demographic, social determinants of health, and health status variables previously referenced. And so we've shifted from kind of a broad set of input features to somewhat more specific interests in specific variables here. I think that's emblematic of the shift to more numerous source attributes, but more limited overall types of information than proposed, or at least than was referenced in public comment on what was proposed. In the proposed and final rule, the selection of source attributes was really guided by 4 key principles. We looked for what was most frequently included in the academic literature and other reporting guidelines, what was most meaningful and interpretable to users and developers, items that were focused on equity, fairness, and bias, and items intended to show that the model would perform effectively outside of the specific context where it was developed, sorry. The goal of the finalized source attribute list is really to establish a consistent industry-wide foundation upon which others can build and customize. We're aware of numerous industry and academia-led efforts in this area. We've worked to balance prescriptiveness and specificity with flexibility to accommodate a range of applications. And the source attributes align with existing reference material from NIST, the White House, and White House executive orders. Next slide. The last piece I'll mention under source attributes here is the ability to modify these source attributes. So we propose this as the ability to author and revise source attributes and source attribute information. And we finalized it as the ability to modify these fields and information. So a shift in language with some implications. And really the requirement here is that for evidence-based and predictive DSIs, the Health IT module must enable a limited set of identified users to record, change, and access related source attributes. So this again speaks to if a user integrates or otherwise has access to decision support interventions that are not supplied by the developer in the Health IT module, this would provide the ability to provide that source, enter that source attribute information so that other users could review it on their own. For predictive DSIs in particular, the Health IT module must also enable that same a limited set of users to record, change, and access additional source attributes not specified. And so this would be for things like information related to monitoring and surveillance in the local setting and post-deployment, customization to local and specific needs. It would again support customers that use self-developed predictive DSIs or other party developed predictive DSIs. We think in combination, these tools will be useful to support the independent review for decision support relevant to clinical decision support under FDA's authority and meeting the criteria for enabling independent review for non-device clinical decision support as separately determined by FDA. So essentially in giving these tools to users, they can ensure that CDS that otherwise meets the definition for non-device CDS can also enable independent review by a clinician of the basis for the output of the decision support and facilitate meeting that definition through the FDA. And again, allowing the ability to modify these is intended to accommodate emerging source attributes, the emergence of consensus, varied uses, settings, and predictive DSI types that may have different source attributes that are relevant for them, such as the use of large language models and generative AI, which would generally meet the definition of predictive decision support interventions. Next slide. In the proposed rule, we included a request for comment about whether or not this source attribute information should be publicly available or accessible. And at this time, we declined to require public disclosure of source attributes. I will note there are kind of 2 buts associated with this. One is that as the industry gains experience making this information available, we may consider broader and public availability of source attribute information in the future. And then we'd also remind parties that under current program requirements, users have the right to discuss the performance of their certified health IT, and specifically that's according to the communications condition and maintenance of certification requirement, which states that users have the right to describe relevant information on their experience using a health IT module. And we note, we clarify that source attribute information is among the kinds of information that customers may freely discuss publicly. So it is covered by the communications condition in essence. Next slide. So the second kind of plank in the transparency effort here relates to intervention risk management for predictive DSIs. And so walk through some of the requirements there in the next few slides. Next slide, please. And I'll start again with what was proposed, which was a proposal that developers of certified health IT that attested yes in the predictive DSi attestation statement would employ and engage in intervention risk management practices for all predictive decision support interventions, not just those that they supplied, that they would then compile detailed documentation of intervention risk management practices and submit summary information to their ONC ACB regarding those intervention risk management practices via a publicly accessible hyperlink, and then review annually and update that information. In the proposal, we proposed that this work would need to include risk management information related to other parties' predictive DSIs, that is, those beyond what are supplied in the Health IT module. And commenters expressed significant concerns that these requirements would require disclosing IP or proprietary information, particularly from other parties to developers of certified health IT, that they could compromise patient privacy, and that it could increase administrative burdens on the developers of certified health IT. Next slide. So the final requirements for risk management really reflect many of the practices included in the proposal, but with a reduced scope focused around that configuration nexus that Jeff described. So here it's that intervention risk management practices must be applied for predictive DSIs supplied by the health IT developer as part of its module. These practices include a focus on 8 characteristics for which risks must be managed, and we've listed those here. And for these characteristics, predictive DSIs must be subject to analysis of potential risks and adverse impacts, practices to mitigate identified risks, and then policies and implemented controls for governance, including around how data is managed and used. The final rule preamble goes into more detail on each of these characteristics, but I'll just note that we relied and leaned on the NIST AI risk management framework quite heavily in developing this approach to intervention risk management in the ONC certification program. And so the summary here is we have not finalized that developers review risk management information for other parties or include that risk management information in part of their documentation. We have also not finalized the need to provide a detailed documentation on specific interventions, rather have finalized the publicly available summary of information. Next slide. I think there's animation. So within the final rule, we've included several best practices or should statements or recommendations for what this risk management practice should include. And really this is focused on the 3 required risk management activities: risk analysis, risk mitigation, and governance. So risk analysis, we state, should include estimates of the likelihood and magnitude of negative impact, to whom each risk applies, and the source of each risk. Risk mitigation should include practices to prioritize risk, to mitigate or minimize identified risks, change control plans, similar to what's described by the FDA in recent draft guidance, processes to supersede or deactivate interventions that deviate from their intended use, and approaches to include subject matter experts in developing measurements and validating performance of these tools. And those subject matter experts could and should, we state, include diverse representatives, including patients. And then the third piece here is governance, which we state should include an effective framework for risk management with defined roles and responsibilities, and then setting and enforcing priorities for managing and using data. Next slide. Moving towards a wrap up, we've laid out the specific implementation timeline as it applies to various actors. So for health IT developers, we'll have 1 year to update certified health IT to support the capabilities in B11. And that 1 year timeline is finalized as proposed, whereas several other timelines in the final rule were pushed back. We've essentially prioritized and kept constant the proposed timeline for this criterion. developers will need to provide updated technologies to their customers by December 31st, 2024, and that as well as provide summary risk management practice information to their ONC ACB by that date. And then moving forward, they'll need to keep source attribute information and risk management up to date. And B11 will now be included as part of real-world testing. For ONC ACBs, they will need to post a hyperlink to summary intervention risk management practices by December 31st, 2024. For providers, as of the 2025 performance period for CMS payment policy, Certified Health IT will support access to and the ability to modify source attribute information for evidence-based and predictive DSIs. For the industry at large, we think this will establish a baseline of 31 types of source attribute information, which will then allow the emergence of a industry consensus and an information ecosystem. And fundamentally, transparency is likely to incentivize the creation and support of fairer, better validated algorithms in healthcare. Next slide. A couple of quick wrap-up slides, kind of zooming way up from the details of the specific requirements around source attributes and risk management. And give a sense of really the objective of the policy. Next slide, please. So fundamentally, the DSi certification criterion is most directly aimed at improving transparency around how decision support interventions, including both evidence-based and predictive decision support interventions, are designed, how they were evaluated, and how they perform. And this enhanced transparency is intended to then enhance the trustworthiness of these tools so that users have clarity on how they were developed, how risks were managed, and how they performed. And ultimately that this will foster an information ecosystem that, what our requirements will really serve, we believe will really serve as a baseline or foundation for, and that ultimately will help organizations and users determine whether their predictive DSIs are fair, appropriate, valid, effective, and safe, select to use those that are faves, and mitigate the use of those that are determined not to be fair, appropriate, valid, effective, and safe, leading to overall greater use of trustworthy decision support. Lastly, we think this information ecosystem will advance health equity by design by addressing bias and health disparities, including those that are propagated or could be propagated by predictive DSIs that are not faves or that are not fair. And ultimately, we'll expand the use of technologies in safer, more appropriate, and more equitable ways. Next slide. At ONC, we're aware and work closely with our federal colleagues. We know we're not the only game in town. And so here we'll highlight two other HHS agencies that we've been in close collaboration with, who have ongoing rulemaking or other regulatory role in this area. The first is the Office for Civil Rights, who have a proposed rule relevant to healthcare providers, health plans, or recipients of financial assistance from HHS. And that essentially says that those entities should not use clinical algorithms in discriminatory ways. FDA has a set of guidance documents relevant to clinical decision support in device software functions. And really, this is relevant for manufacturers of device software functions, so medical device manufacturers. And what must be done, those folks go through a rigorous FDA approval and review process for those things within FDA's purview that's focused on demonstrating the device software function safety and effectiveness. ONC has separate and distinct authorities from these two agencies, but closely related ones. And our focus relevant to both of these is on, as we've said several times now, on transparency related to predictive and evidence-based decision support interventions. Our requirements are most directly relevant to developers of certified health IT that supply a predictive DSi as part of its health IT module. And really the goal here is to enable users to access predictive DSi performance information, risk management information, and that information be kept up to date by the developer of certified health IT. Next slide. I think with that, we've gone through our planned presentation and have about 10 minutes left to address question and answers. I see a number have been entered in. Also happy to address questions from folks if they want to put their hand up. We can put a spotlight on you.
All right, and I'll hop in real quick as we see if we have folks that want to put their hands up. I'll note a couple of things. We've got access to all of the questions, and we'll do our best to make our way through as many as we can in the time that we have. But also, these questions are really helpful for us in terms of understanding what kinds of clarifications we may need to provide and what kinds of information we may need to consider for inclusion in educational materials. So I'll start there with just a couple things. I know that there are a number of questions around test scripts and conformance methods and things like that. I want to make clear that developers of certified health IT who wish to certify their health IT modules to B11, and that is the DSi criterion. The full is 170.315 B11. Developers that want to certify their health IT modules to the DSi criterion will do so via attestation. And those developers should look to their ACBs to understand kind of what kind of documentation will be required. And I'll note that this is the same for the conformance requirement for the existing certification criterion at A9, which is the CDS criterion. So there's no real change in what will be required to be certified to this. Now, obviously, the attestation will essentially require you to say that your module does all of the things that we are requiring, and you should look to the regulation text and associated preamble for that. I will also note that we're working on trying to get a DSi resource guide out the door as soon as possible. So no guarantees on that, but we're looking to get that out sometime within the next, I would say, 2 to 3 weeks, maybe a little bit longer, but we're working diligently to try and get that out, and hopefully that will provide you with some sense of what we expect. Again, though, the requirement for certifying to B11 will be through attestation to your ACB, and you should, at some point in the near future, contact your ACB regarding documentation requirements. We also got a couple of questions around source attributes and how they should be displayed to users. And we did not go into that. So the requirements are that a limited set of identified users have access to source attribute information. And this really does mean what it says, a limited set. And that limited set could be the entire population of the customer base at the point of care, or it could be a set that is more limited than that. It could be something that is, so we left that decision up to the developer and its customers. So I think it's important to note that we're not being prescriptive, we're providing flexibility on that front. And in terms of requirements around the information and how it's formatted, we have no requirements around that. We have categories of information, and we've got a series of 31 data points, descriptions, and other key pieces of information that we want as part of source attributes, and those need to be available to a limited set of identified users. But we're not being prescriptive in how that information is broadly made available. And also, we're not being prescriptive about when that information is available. All of this is up to the customer and to the developer to determine. I don't know, Jordan, if you saw any messages or questions that jumped out at you as you were going through. I'm certainly happy to reiterate a couple other things, but I'll pause there first.
I think you can go ahead, or we can open it up to, I see a few hands up.
Okay. Yeah, great. Why don't we open this up?
Okay, the first hand I see is from Ginny Meadows.
Oh, I'm sorry. My hand wasn't supposed to be raised.
Okay.
I already asked my question. You answered it, Jordan. Thank you.
Sure. Then I see Susan Apgar. I think if you can come off mute. Looks like another disappearing hand. And last one here, last hand up I see is Heather Lane.
Hi, thank you. I dropped a question in the Q&A that hasn't yet been addressed. I just want to confirm my own understanding of what you said around the scope of what's included in predictive DSi here. Specifically, if we have a predictive system and like an AI-based system that is used entirely within our internal administrative processes, but to serve things for our customers. So an example I give is if we do like claim coding on behalf of our customers, and we use an AI system to support our claim coding, but the AI system does not face the users, it does not face the clinicians or their staff. Would that thing be excluded from this because it's not a user-facing workflow?
So I think it's important. So a couple of things. We might need to get a few more details on that. And I think we're going to come up against a lot of these. Does my technology meet the definition? And if so, does it subject to these requirements? I think the two really important things to kind of keep in mind is whether or not the technology truly does meet the definition of a predictive DSi. So it meets that kind of three-part test. And then and I assume you're speaking from the position of a developer, a certified health IT developer, not a customer of a certified health IT developer.
That's correct. We're a developer.
Okay, and so really those are the two big important aspects to look at. Is does it meet the definition of predictive DSi? And as a developer of certified health IT, do you supply this as part of your health IT module? And if the answer to both of those questions is yes, then we would expect that users of your system would have access to, a limited set of users would have access to the source attribute information, and we would expect that you would do some kind of risk management related to that predictive DSi. We did not finalize any construction around specific use cases, so just because it's not a patient-facing use case does not in and of itself exclude it from the requirements at B11.
Okay, so I hear that, but in one of your previous slides, you had a scope statement that said, as I recorded here, actively presented to users in clinical workflows. And so I guess I'm less interested in the specific use case here. I think the kind of hypothetical I'm describing would be considered a predictive DSi, but I'm interested in the actively presented to users clause, because I'm envisioning something that is only used internally and not presented to the users.
Okay, yeah, so the actively presented in clinical workflow piece was specific to evidence-based decision support interventions. So these are going to be more rules-based, not derived off learned relationships. So again, I would encourage you to take a hard look at the predictive DSi definition. The actively presented is how we define evidence-based, or how we describe rather evidence-based decision support interventions for purposes of the program.
Okay, thank you.
Okay, thank you. And obviously we've got, I don't see our contact information up there, but happy to we've got a Health IT feedback and inquiry portal where you can ask questions, and we can also put email address into the chat for those that have questions. And I don't know if we can quickly find the Health IT feedback and inquiry portal link. That'll be the best way to actually contact us, because there we go. Awesome. Thank you, Cannon. That way we can track your question and make sure that it gets answered. You can send me an email, but we're not tracking my email, so I'll do my best. But do appreciate those questions. And we've got, I guess we're right at 2 o'clock. Do we have any other hands up? Oh, you're on mute, Jordan.
Oh, sorry. Yep. There are still, 4 hands up and 52 questions in the question and answer portal.
Do we have one more question we can take, and then yeah.
I see Justin Berg is the next hand.
Hello, thank you for taking my question. It's actually in the QA, but it was just the last one added. No one answered it, but it was another question on if this feature would be included in the predictive support, predictive support engine. So for the ambient listening that would only use the patient-doctor conversation to produce a transcribed note, I would assume that is not included in the predictive, right? Because it's not using anything from the EHR, it's just using the doctor-patient conversation. Am I right in thinking that is correct?
So that's
Generally,
interesting. Yeah, go ahead, Jordan.
Generally, the definition for predictive decision support isn't dependent on where the data used as input into the decision support is coming from. So in this case, it's coming from a recording. And then if that predictive decision support intervention was supplied in the Health IT module, it is reasonably likely, right, to meet both the definition for predictive decision support and to meet the scope if it's supplied in the Health IT module.
But yeah, there'd be no source attributes, right, used. Yeah, so confusing to me. Okay, thank you.
Okay, and I'll just, I think it just a real quick as we close up, because I did see some questions coming in relative to what supplied by means. I would encourage everyone to look at the final rule and do the Control F for supplied by and try and get clear on what those details are, and then send us questions when you're not clear on your specific situation. But it is important to note that health systems or hospitals that develop predictive DSIs and use their certified EHRs or certified health IT to kind of deploy those predictive DSIs are not likely subject to our requirements unless or until that certified health IT developer decides to take this health system developed predictive DSI and then supply it to other customers. Along the lines of what we went through in this presentation and along the lines of what we described in the final rule. So at any rate, just because you have a predictive DSI, just because it's used in a hospital, and just because it interacts with or a health IT module doesn't mean that you're necessarily subject to those requirements. So please do keep that in mind. We are at time. So I just want to say thanks to my colleague Jordan and to my colleague Cannon and to our good friends at Kaufman and everybody who helped produce this. Thank you for your time and attention. These slides will be available alongside the presentation, likely within a few days. And thanks for joining.